Welcome to this webinar on this lovely Wednesday evening. You're very welcome to join us here. My name's Sharon Neal and I'm the current Vice Chair of the Society of Tissue Viability and a lecturer in adult nursing and researcher at Ulster University in Belfast. So this webinar this evening is where we're going to have a little bit of information and discussion around our republication of the seating guidelines. So I'd like to welcome all the panelists that I have here to join me this evening. First of all, I'd like to introduce Melanie. Melanie is an Associate Professor in Adult Nursing at the University of Salford, England. She's a health and social care researcher who has conducted studies with colleagues regarding pressure, redistribution and seating, nighttime positioning equipment, virtual wound care, and has had placements in Uganda, and more recently, the impact of interprofessional student training in care homes. Melanie is the lead author of our updated guidelines, so thank you for joining us, Melanie. Next person I want to introduce is Professor Stephen Duckworth. Now, unfortunately, due to unforeseen circumstances, Stephen's not been able to join us here this evening, but he has played a really significant role in the review of our seating guidelines, so I feel his introduction is still warranted in his absence. Stephen is medically trained with an MSc and PhD in disability and rehabilitation. He has been an electric-powered wheelchair user for 43 years following an accident as a medical student. He is currently the chair of the PPIE, and I'll let Pete, whenever he talks a little bit more about him later, explain what that is. University of Southampton, the research project investigating the use of continuous pressure monitoring to reduce the incidence of pressure sores. Stephen, like I said, was a peer reviewer on our seating guidelines. Thirdly, I'd like to welcome Eva. Eva is qualified as a registered nurse 9 years ago and worked initially in the community, rapidly developing an interest in tissue viability. Eva's been working in the field of tissue viability for the last 7 years and progressed to the operational team lead for the last 3.5. She's particularly interested and has speciality with pressure and posture. She's been instrumental in shaping and developing a contracture awareness programme, working in partnership with therapy leads within the organisation and the regions that she works. Eva is also a member of the regional 24-hour posture group and has been recently appointed to the conference board for the posture mobility group. She's a clinical user of the existing seating guidelines and is looking forward to integrating the latest version into our practice. And last but not least, just like to introduce Pete Worsley. Pete's a professor of assistive technology and tissue health in the School of Health Sciences at the University of Southampton. Pete, like myself, is also a trustee of the Society of Tissue Viability. He's a qualified physiotherapist with a PhD in bioengineering, where he developed an interest in medical device innovation. He leads Southampton's skin sensing research group based in the clinical academic facility at Southampton General Hospital. Pete's also a co-author of the revised seating guidelines. So again, thank you and welcome to all our panel members here. We have a little bit of an agenda, quite informal agenda set for this evening. We're going to let Melanie kick off first with a little bit of a background to the seating guidelines, where we had asked Stephen to come in and talk to us about the potential impact of these seating guidelines for patients and people who spend a long time seating out in the community. We're going to ask for Pete to just give us a little bit of a brief overview instead of the work that he has done with Stephen and the impact on our seating guidelines. Then Abe is going to tell us about what the seating guidelines mean for health and social care workers. And then we're going to open the floor to yourselves in the audience for questions, answers, comments, queries that you may have. And hopefully you've all had a chance to look through the drafted seating guidelines.
First of all, I'd like to say that it's been an absolute delight and pleasure to be the person who's led this third edition of the seating guidelines for the Society of Tissue Viability, and just to see all the names on this slide of the wonderful authors, co-authors and participants who've been involved, and you'll see that it truly is a multi-professional team. So I think it's really important to acknowledge everybody's involvement and how collaborative and collegiate everybody's been. So we wanted just to give you a snapshot because this webinar is not very long, and we wanted it for it to be more participatory than from listening just to me. So we wanted to create a diverse group who would author the guidelines, and obviously our objectives were to update and revise the 2018 guidelines that you probably used in your day-to-day clinical practice or practicing care. And we also wanted to report on the current evidence base that has changed and evolved since 2018, not just for people who remain seated for long periods of time, but for those who care for them, maybe work in health and social care settings, and for obviously think about people like me and academics who then also facilitate modules or in regards to tissue viability. And also one of our other objectives were really to examine the different types of cushions and chairs available and their interventions that all relate to the prevention and management of pressure ulcers for adults. So we're particularly focusing on adults who sit for long periods of time. So we just wanted to highlight what this process involves because we wanted to ensure it was robust and rigorous and also included service user engagement. So like any production of guidelines, it always starts with a review of the literature. And this includes conducting a significant search of the literature, using keywords, using frameworks to ensure that we're getting the latest evidence base so that we can collate that, praise that and include it in the latest guidelines. And as said by Sharon, we want to acknowledge the service user engagement and in particular the work of Stephen in helping us with these the authoring of these guidelines. Not only did he review them for the use of plain English language, but also from a service user perspective to ensure that the language within it means that everybody can understand what it means to prevent and manage pressure ulcers, whether you're the adult who's receiving pressure ulcer prevention care or management, to actually the staff who are delivering that care. And as a really cohesive group, we allocated sections of the guidelines to develop and write based on our knowledge, our skills, our expertise, and also our interests. And as they started to develop, we had regular meetings with something called peer review, and this is where we constructively critique each other's sections to ensure that it meets what the society wants, but also it meets what the evidence base is saying. And our final bit of the process was to ensure that the trustees from the Society of Tissue Viability were happy with the guidelines and they'd read them and made sure they reflect what's happening out there in health and social care practice. So hopefully you've flicked through or read them, and you can actually see since 2018 we have updated and added things. So you'll see that we've changed the title and we wanted to include everyone because we know that pressure ulcer prevention and management is everybody's business, from the person who may be at risk or who has some skin damage to the carers, the registrants, the academics, the scientists, industry. It's everybody's business. We're all here. We don't work in splendid isolation. We're here to improve the care and management for people who are at risk. We also included in our background section new aspects. One of them was in particular Stephen suggested as the service user that we really started to explain what pressure, shear and friction meant so that service users, lay people could understand. We also found that there'd been a huge survey that had been conducted across Europe that highlighted that less than 50% of at-risk people actually receive a specialist chair or cushion. They might receive a mattress for their bed or a heel protector, but they don't actually receive a cushion or specialist seating. We also noticed that reposition is often irregular time intervals for that group of people who responded to this in Europe. And a very small proportion of people are given care plans, even though they may sit for long periods of time. You'll also see in the background section the new categories and the staging systems from category 1 up to unstageable. And we included all skin tones because what we want to do living in a multicultural society is reflect the people who we care for. You'll see in the risk section, again, Stephen was really instrumental in this, that service users need to know when we're talking about risk assessment tools, what are their name, how are we using them? So we've included those in our guidelines too. And then change the terminology in the optimal seated position section. So again, it becomes more inclusive for all who are involved. We also have a section on interventions that will take place after a seating assessment. And in this section, we really wanted to expand further this issue of equipment abandonment. And what we've learned, and it's sadly from assistive technology and not really from equipment abandonment of pressure relieving and redistributing equipment, there are actually 6 key things of why people decide not to use a mattress, not to use a cushion, not to use a chair, not to use the wheelchair. But we felt that these were really pertinent and resonated with the people we care for. And also we've looked at some of the features and priorities that have changed in regards to us as health and social care professionals, what we see as important in regards to prescribing a piece of equipment to that of people who are actually receiving the equipment. And other things you'll get to read around, and we hope you'll really enjoy, is thinking about the new types of cushions, thinking about what you should consider when you're going to purchase or renew a cushion or seating. And then really important, because education really helps us all, is these self-help suggestions. And again, as usual, we've adapted the asking framework to add a small s for sickness, because we know that when somebody's unwell and they start to feel sick, they increase the risk. The skin, because it's the largest organ of the body, it's the one that shuts down the quickest when we're not feeling well, and recognizing that when we're sick, the skin becomes more susceptible from damage from pressure, shear, friction and moisture. And then also we wanted to include standards of how to test cushions and seating, so you can maintain them in good condition and look after them, but also be alerted to when they need changing. So again, really important aspects of the new seating guidelines. So we're hoping, obviously, that you've had access to the guidelines. We're hoping that soon you'll start to download the paper from the Journal of Tissue Viability, which is open access. So that means that those working in health, and in particular the social care sector, who may not have access through NHS library services, can access that. And also we have an at-a-glance leaflet as well.
Pete's just going to very briefly just tell us a little bit more of Stephen's story and how much he's helped us within this review. Thanks, Pete.
So first and foremost, Stephen is a remarkable individual. So he was training as a medical doctor and actually had an injury playing a rugby match when he was just 21 years old. He went on to complete his degrees amongst PhDs and lots of other things, as you can see by the number of letters after his name. But Stephen was obviously had a high-level cervical injury and was therefore confined to his wheelchair for much of his life since the injury. But despite the obvious physical impact, a significant role nationally and internationally across a number of different organizations that you can see listed there, including leading his own global disability charity. But when I first met Stephen a few years ago, he'd come across a real problem. He started to get pressure ulcers. So back in his early 20s, he was managing his health very well. He could reposition, and obviously his skin and soft tissues were in such a state where he could manage pressure ulcer prevention quite happily. But as Stephen spent the last sort of 40 years in his chair, his skin and soft tissues have changed. They've become much more vulnerable. And Stephen was really stuck because actually he kept on getting sacral pressure ulcers. And that meant he used to spend prolonged periods in bed rest, and he couldn't fulfill all of these amazing roles and responsibilities that he'd taken on, as well as obviously the effect on his quality of life, seeing family and friends. So with Stephen, we brought him into Southampton General Hospital. We used cushion and tilt in space chair. I was able to give Stephen a live view of the pressure image as he actually went through his pressure relieving routine, which is typically tilting his chair back to relieve his buttocks. And he could see how he was originally positioned in terms of his posture, and the magnitude of the tilt in his chair actually wasn't relieving those skin sites that were very vulnerable to pressure damage. And so by looking at the pressure mapping in real time, Stephen could modify the way he moved in his chair and actually create strategies which meant he had better relief of the pressures and therefore long-term management of his skin health. And we also talked through other strategies around making sure if he's being hoisted, that we were ensuring his skin was protected as much as possible, the use of prophylactic dressings and other devices that can protect skin health. And for Stephen, that was a bit of a revolutionary moment because it meant he could finally manage his skin health and manage it more effectively with the carer support and his family that he was currently using. And as a result, Stephen very willingly took part as our chair of patient and public involvement in Southampton. So he actually actively has sought out other individuals with lived experience of pressure ulcers who directly feed back into our research and the research of others to help ensure that the program we deliver is grounded in what's really needed for patients. And Stephen's a huge advocate for making sure that the unmet needs are also addressed. So reaching out to individuals who wouldn't normally take part in research, making sure we get to individuals of every different type of ethnic and social background to make sure that everyone has a voice. And when the guidelines came around, Stephen sort of bit our hand off in terms of getting involved. So Stephen's a huge advocate for sharing knowledge, making sure that it's disseminated, but disseminated really effectively. So Mel and Sharon hit the nail on the head where Stephen was incredibly fastidious about making sure we had our wording correct, that we had the imagery correct, and that we made sure that the guidelines really were appropriate for all. So we were incredibly grateful for Stephen's time, his knowledge, his awareness, not just as someone who uses a wheelchair and has had pressure ulcers, but also all that breadth of knowledge and understanding he's had from these various different roles and responsibilities in his life. So it's a real shame that Stephen can't be with us today because his voice is incredibly powerful, and it's had a huge impact on us as a team putting the guidelines together. But I'd like to pay tribute to Stephen for what he stands for and who he is as an individual and his impact today. Thank you.
Thanks, Pete, for that wee summary and for doing that really much on the hop. When we go over to you now, Eva, just to take us through what the seating guidelines can potentially mean for members in the audience here that are health and social care workers. So thanks, Eva.
So I thought the best way to share what it means for clinical practice, particularly where I work, but where for everyone here works as well, is probably to just talk through a case study. I don't have any images or anything, so I do apologise. But I do have consent to share her story, and I think it's very relevant for the new seating guidance. So I have a lady, and she's 60 years old, and she has MS, and she has incredibly complex posture, which includes a scoliosis. So she has changes to her spine. She has a pelvic obliquity, so it means that her pelvis is tilted and up on one side. Her pelvis is rotated, so it's forward on one side compared to the other. And her legs are windswept, so her knees are contracted and quite tight, and they both go off to one direction. And I'm sure that you've seen patients in your clinical practice, no matter where you work, that this sounds quite familiar. So this lady did have a wheelchair, and she did have a seating provision, and she did have some pressure relief in her bed. But unfortunately, she went on to develop a category 4 pressure ulcer on her left IT, so her left bum bone, and a category 3 pressure ulcer on her left heel. So we needed to obviously go in and reassess. So I think my first point for clinical practice and the guidance is the importance of reassessment. So just because somebody's had an assessment at some point, it's really, really important to reassess. Patient's posture changes, patient's overall condition changes. So if something's not going right, we need to go back to the basics and go back to the beginning. So we did a complete reassessment, holistic assessment of her. So we assessed her bed positioning and completed a complete postural assessment of her in lying, and was able to implement a new postural positioning regime that was able to offload both her heel and her bum bone. We then moved on to seating. So although she did have really significant harm, and at the time she was then moved on to bed rest, which is quite common for patients that have got significant harm. And like we've just heard, actually, when you then go on bed rest, it's incredibly impactful for your quality of life. And my lady was no different. Her eating and drinking was affected, so nutrition and weight was compromised. Her overall well-being, how she felt about herself, her self-image, her ability to interact with her family was all compromised by her being in bed. She hated it. So we obviously managed the wound, and I know that most people on here are going to know how the sorts of things that we would do to manage a wound, but this is a bigger perspective. So her wound was managed appropriately, but then we looked at seating. So we reassessed her wheelchair, and again, I think my second most important point probably is collaboration. So her bed system assessment was done by tissue viability, community nursing, her family, herself, and specialist OT. We then moved on to a wheelchair. So that was wheelchair services, specialist OT, herself, her family, and again, myself, where we molded her and then we pressure mapped her for her seating. We then looked at her comfy chair, and did a complete reassessment for her chair, for her posture to support her. We pressure mapped her seating so that we could again optimize comfort for her, but also pressure relief, pressure redistribution, and obviously with aims to heal but still meeting her needs. So that was another collaborative approach. We also have started to look at her shower seating, because where her pelvis is tilted, it means that all of the pressure is going on one bum bone rather than both bum bones. So again, that increases her risk factor. And she's a full hoist, non-mobile lady. So when we then move her into showering and personal care with the carers, with a sling, when she's on a shower commode, she can be sat there for quite an extended period to be able to support her and then come off again. So again, I think it's the point about holistic assessment and again, that collaboration. So I think everything that's in the guidelines we utilised with this lady. And so I think is the importance of the clinical guidance, no matter what area that you work in. The carers were so important in being able to feed into what worked for her on a day-to-day basis, her slings, her comfort, us being able to support and teach them how to seat somebody in adapted seating and molded seating with a sling in situ, her family being involved, her being able to go out and use her wheelchair in her car and go out and about for appointments, to go and visit people. So we were able to optimize all of those things. I'm really pleased to say that in, I think it was 3 and a bit months, 3 to 4 months, I would say, this lady fully healed with all of these interventions. And it was a lot of interventions and it was a lot of hours, but it was so worth it. Her category 4 went on to fully heal. Her category 3 went on to fully heal. And she's now loving life, sitting out more regularly in her chairs. But again, I'll bring you back to bed positioning as well. These are seating guidance, but particularly for seating assessments that we've put in for patients and for molded seating for wheelchairs and other types of seating. If we don't maintain 24-hour posture and bed positioning, then somebody's position and posture can change rapidly while they're in the bed, and then the seating assessment is no longer appropriate. So the seating guidelines are so important, but 24-hour posture is also incredibly important to incorporate it in that collaborative approach, I would say. So that's a little whistle-stop tour of my lady and how the guidance fits with me in my clinical practice.
Thanks so much for that, Eva. That was really useful, and I think you're absolutely right. As much as these are seating guidelines, but patients are spending 24 hours in bed sometimes, and utilizing their bed as a chair device for sitting upright. So we need to give that due consideration as well. So you've perhaps talked yourself into a little project there, but that's great. So yeah, there's been some. Just for the panelists' information, there's been some fantastic comments coming in through the chat here. Everybody's feeling really positive and really delighted to see the new publication of the guidelines. I think everybody hopefully will get some more questions into the Q&A. I think we've two on standby, but I'm going to start with one of my own, if that's okay. So this question is for Melanie, just to get us going. You mentioned in your presentation about equipment abandonment, and it just, although I don't work in clinical practice anymore, it's something that just rang alarm bells with me. We can provide all the equipment in the world and do all the assessments, but if patients aren't prepared to use it, what we can do about it. So can you tell us a wee bit more about that, and maybe if you've any tips or hints for patients or for our healthcare professionals in the audience? Melanie, thank you.
Thank you, Sharon. Yeah, the term equipment abandonment actually came from America, from Barbara Crane, who actually is from the University of Pittsburgh or Philadelphia. I think it's Pittsburgh. Correct me if I'm wrong, Pete. And she did some work on seating with people who were wheelchair users and recognised that occupational therapists and wheelchair services often saw equipment in the bathroom, under cupboards, in people's houses that wasn't being used, in particular in relation to their wheelchairs or their cushions and other equipment. Not looking at equipment abandonment in detail, but actually looking at more of assistive technology. So we looked at that as part of the guidelines and recognised that actually there are many reasons why people decide not to use the equipment that they're given. First of all is many companies, and this is for industry, that actually the design and function of assistive technology or mattresses and cushions actually doesn't have end user or the person in the design process. So it's really important for the industry that if they're going to create something that we want people to use to prevent pressure ulcers or to help in the management and interventions, they need to be at the beginning in the design stage. The other things for us as health and social care practitioners is information and awareness. The more information we can give about the cushions and the chairs and why they're useful and how they will help, it really helps the end user, the person who needs it, to really understand why it's important. But also, we from a small study I conducted with my colleague Carol Bartley from OT, one of the authors, is that we actually found that some service provision is people don't get to choose the cushion. And I know that that's maybe because of a loan store system, or it's just you can only order it and it's sent out. But sometimes what we found is some of the end users are like, they don't like the colour, it doesn't match with the home environment, or it's not comfortable, so they're not going to use it. They might kindly take it away or allow it to be delivered, but then they don't want to use it. It could be that there's some psychological barriers, that the chair or the cushion is too big, it's too awkward, it's annoying, and therefore somebody's not going to use it. And if the family and friends or the carers say, oh, that's awful, or that's not a nice colour, it's amazing how simple negative comments can have an impact on the end user using that piece of equipment. And then also societal barriers that create this stigma that, oh gosh, you've got to have a special cushion for your chair, you've got to have a special chair, rather than seeing it as, wow, isn't that fantastic? Look at that chair, is that really helping in managing your skin integrity? And so it's important to garner all that information and to think of these things when we're trying to prevent equipment from being abandoned and then going along a week later and it's there, you know, underneath the stairs or in the bathroom or in another room and not being used.
Okay, thanks for that, Melanie. Does any of the other panel members, Pete or Eva, do you want to add anything to that before we move on to our next question?
I just think I'm just backing up Melanie's comments around certainly the work we've done recently with lots of different tissue viability teams is around making sure the cushion is fit to the person rather than putting a cushion the other way around, if you like. So it's that sort of personalized approach of, yes, people might need immersion, but they might also need some support for their postural and sort of mobility elements, which are key for pressure relief as well. So it's kind of seeing the person holistically, what's going to suit their needs, what suits their environment, as well as the pressure relief characteristics.
Thanks, Pete. Eva?
Yeah, I would agree. Again, I'm sorry, I like a case study. You know, I think patient experience and feedback is just so powerful. So I had the opportunity to be with a young boy, 21 years old and wheelchair user. And he, like Melanie said, his whole identity is wrapped up in the chair and not wanting the chair all at the same time. So his choice for the chair, the colour of the chair, the foot plates, the cushion, how low the back was, the fact that he didn't want side pieces. I mean, he was incredibly prescriptive about the chair and what the chair was for him. And I think that's because the chair was an extension of him. And I think it's important for us to remember that these people that we look after, usually the equipment that they're using, they need to use a lot of the time. And therefore it's part of them. And so their choice and how they feel about things is really important to consider. To the point where this young lad, you know, when he was with his friends, if he was having a photograph taken, they would put all their arms around him and they would stand him. So all the boys would stand in a row for photos, and then no one can see the wheelchair. So his identity was still really conflicted between needing the chair to meet his identity and his needs, but also not wanting to be identified as a wheelchair user and somebody that is in a chair all the time, and how he projected his identity. So I just think it is really important to, you know, talk to your patient and find out what their needs and their wishes are in order for us to try and get outcomes that are both beneficial for us as clinicians or carers and for the person who is seated. And comfort is, you know, probably the primary thing that most people want. And if we can meet in the middle and have comfort and patient choice and have clinical outcomes optimized, then we're ticking everybody's boxes, which I know might sound a little bit like a perfect world sometimes, but I think if we don't strive for it, then we won't have any change. And again, the seating guidance guides that beautifully.
Yeah. I think that sums it up nicely, Eva. You know, we do have to be aspirational, because if we accept less, then, you know, that's the standard that we're going to reach, and we're never going to get better or make our patients' experience better. So I'm just going to pick up a question from the audience here. So sorry, Eva, I'm coming back to you. This question for Eva. We have challenges with patients who wish to stay out in the chairs, who may not always agree or choose on having a period of bed rest, but there has not always been the time to get chairs, etc., fully reviewed before deterioration in pressure ulcers, which sometimes occurs. As a TVN, do you have any advice on what is your experience with this? So I think what they're asking is that delay between highlighting risk or maybe change in skin circumstances and that delay in having the seating reviewed. Have you any advice around that?
Yeah, so I think that's something that we still do experience. And again, I keep relating it back to the guidance, but that's the point of the webinar. And I think it gives you that really good overview of what to expect. I think healthcare is really challenging at the moment, and sometimes we can be quite reactive, rather than proactive. And I think being mindful of seating assessment and what the patient needs. Again, going back to that patient choice, we're asking people to have bed rest, but people decondition really quickly. They lose their independence, their quality of life, their ability to eat and drink properly. So I think if we can try and be a little bit more proactive and again collaborate with OTs and physios and network in your area, I think networking is key. Networking is amazing. If you can get to know people in your equipment stores, your wheelchair services, your long-term complex needs services, your funding panels. If you get to know these people, then your ability to navigate, the environment is better. And then by being really proactive, you can go out, see your patients, assess their bed needs, but also assess their seating needs, and be able to proactively try to put a holistic plan in place that again meets their needs of wanting to sit out, but also meets our needs clinically at trying to prevent pressure. It is challenging and time, is a challenge. But again, I think if you're having those conversations with people, and that they know that you're being proactive and that you're trying to get something that will benefit them in place, sometimes that they can be a little bit more accommodating and will have a period of bed rest. I have a chap that is on bed rest at the moment, again, with a healing category 4, and he knows that we're just waiting. We've done all of his assessments. We've done his seating assessment. We're just waiting for his provisions to come through, and then we'll remap him with the equipment, and then he can start sitting out again. And he's okay with that. He didn't want to have some bed rest, but he knew that that was the best thing after we explained it, and that it was a really short-term measure so that we could then get him seated out safely. I don't know whether that again has answered the question.
No, definitely. And I think there's potentially another question there in the Q&A that you've sort of started to talk about there at the end in relation to what can we do if our patients or our seated individuals don't want to go on to bed rest. What can we offer them? So you started to touch on that as well, which was great. Thank you. My next question then, I'm going to come to you, Pete, if that's okay. So being our resident bioengineering expert, we're going to ask you if you're aware if there are any emerging technologies or new innovative devices out there, or way we can use things differently to help to reduce those pressure points during sitting and help these patients, to live, and for seated longer. And go on ahead, Pete. Thank you.
Thank you. Yeah, so there are some emerging technologies. I wouldn't say they're particularly widespread at the moment, and it's our job to make sure that whatever technologies are developed are appropriate for the settings and the individuals that might use them. Things like pressure mapping have been around for a long time, and actually they're very useful adjuncts in terms of clinical decision making around how we manage pressure care, particularly in seating and lying. But what we're seeing now is some devices actually have instrumented sensing. So I've been working with a company recently. They have a seated system that has air bellows under the bottom, on the sides of the thorax, and on the back. And actually the seat will change its air pressure depending on the position and posture of the individual. And that's something called closed loop. So measuring something and changing something else in the seat. And these are the sorts of technologies that you're seeing coming to the fore in terms of how that might help self-management of pressure care, but also adding a little bit of intelligence in terms of the seating system itself. And I think, we're all getting used to a technology-enabled and digital world. We're all wearing, well, apart from me, wearing smartwatches and are used to getting information sent to us. But the real challenge is making sure we consider all those really important human factors. So what information is relevant to people, either patients, their carers, or healthcare professionals? How do we communicate that effectively? Because there's no point throwing in a wonderful piece of technology if you haven't taken into account the person at the center of it. And this goes for all healthcare innovation at the moment. So there is technology coming, but we need to make sure it's grounded in the patient need.
Thanks, Pete. And before I let you off the hook, I'm just somebody's commented in the chat and just brought it to my attention. We may potentially have some patients and some carers in our webinar this evening, and they're absolutely very welcome. But maybe if you could just explain a little bit what pressure mapping is and how we can use it as healthcare professionals to help and support our patients, that would be really useful for some individuals in the audience. Thanks, Pete.
Sure. So pressure maps are typically a sensor array, and what I mean by that is sort of a flat map with a number of sensors placed inside it. And those come in various different shapes and sizes, and typically they're designed around either seating or a bed application. And what you can do with the pressure mapping systems is visualize the pressure between the bottom and the cushion. And you often get something called a color contour map. So red pressures are very high, blue pressures are very low, caveated with how you set what we call a scale bar in terms of what the colors mean. But what's really important with these pressure maps is you can see the areas of high pressure next to areas of low pressure. And actually, it's those pressure changes, what we call gradients, that are often cause significant problems, particularly around the seating bones in your bottom, those sort of bony bits at the end. And my friend and colleague Dan Bader always had an adage where he used to say, deep sea divers never get pressure ulcers because your pressure is evenly distributed across the whole body. And actually, the thing that you've really got to look out for is where you've got an area of very high pressure next to an area of low pressure. And the pressure mapping technologies are wonderful because they give you a visualization of that. And that can help patient understanding, care understanding, and inform the selection of cushions and postures, etc.
Thanks for that, Pete. Hopefully that will help a few within the audience. So there's more questions in here. We have challenges with patients who wish to stay out in their chairs, who may not always agree or choose to have a period of bed rest, and have not always been in time to get their chairs fully reviewed before deterioration. Do you have any other advice or experience with this? I'm not sure, Eva, if you want to add anything more to that.
Yeah, I was going to say, I think you're right. I kind of answered both questions in one. And I think, is the importance of risk assessment for patients and identifying risk. And, again, the guidance does prompt that. I think it's looking at the wider risks of the patients as well. So yes, we have risk assessment. Have they had harm before? Where is their harm? What does their posture look like? What's their continence? Do they have equipment? There's so many factors to consider. And that's why I think, I go back to collaboration again, but I think if you can bring in, an OT that's going to be an expert in a chair assessment and height and width and all of that stuff that I'm probably less great at, and then maybe a tissue viability nurse or a wound specialist that, knows what they want to optimize from pressure relief and from wound healing, and maybe is more aware of negative pressure devices or, devices that may cause other areas of pressure. I think about being proactive. It's about networking, collaboration, and being able to be really proactive with your assessments. I work in the community, and it's a massive beast, across the town, and everybody's systems work differently, and ordering and assessment and everything is different. But I think the time that you can invest into knowing who are the key stakeholders for seating and for pressure in different areas, that you can work together to be able to be proactive to get something that's best for the patient.
Can I add into that? Would you mind? I think we've also got to remember that when someone's diagnosed with a condition that's going to be long term, and especially may lead to then a reduction in mobility, maybe from a neurological condition, that they then become seated for longer periods. There's something called it's called Shamaz's loss of self, and actually there's a complete change in psychology, that from the person that they thought they would continue to be throughout the rest of their life. And I think it's wonderful when Eva's saying about this multidisciplinary interprofessional approach, because we work with psychologists who are really important to that. And you will see that when you can see I'm sure you've seen it in adults, where you've recommended actually for this short period of time, we're recommending that you're having to go on bed rest, and this is for the best intentions, because we know it optimizes. But you can see in that person, because they're used to wanting social activities and spending time out in the wheelchair, the chair, that there is that loss, but it's having that open discussion with them. And then also people are allowed to make unwise decisions, that is really difficult. And it's not because they're unwise because they're stubborn, I think it is that information given as well. It's that sometimes people don't know, or we don't see the projected long-term outcomes of if we stay in our chair for longer, or if we don't go back to bed for an hour. We don't anticipate that. So again, it's having those honest conversations in a really compassionate and kind way, to say that, and people are allowed, but it's revisiting those conversations on a regular basis. And I think what resonated with me with Pete and Stephen and his contributions is he was able to see through pressure mapping his areas of, and I hear it a lot with people who are pressure mapped, that they get to see those areas of risk. And it's that visual picture gives them a real, oh gosh, is that where it really happens? Is that where the skin is most likely to become damaged? So I think it's also wrapped up in that kind of being aware of all of that information.
Yeah, and I think, that correlation between, like you say, patient education and concordance is clear no matter what aspect of, of nursing care or tissue viability care we're talking about for our patients. If we can educate them as to why we're asking them to do what we're asking them to do, they're more likely to engage with treatment therapies and these types of recommendations. So that does take time and effort. But I think it's well worth the reward when we do get that right. So that's brilliant. Thank you. Pete, I'll maybe give you, this is a bit of a comment really, I think, in the chat, but I think it's worth discussing. There tends to be a lot of confusion around clinician selection between clinicians and AHPs who may have different priorities in the selection process. For example, positioning, posture alignment, chair height, etc. Have you anything that you want to add in relation to that? I suppose about competing priorities, and is it maybe just down to a lack of understanding, of where our expertise is coming from?
Well, I think the strength is always joint decision making between the multidisciplinary team and the patient, and that sort of shared decision making across the team. I always put up a slide when I talk about pressure ulcer prevention, and it's got three main segments to it. So it's got posture, mobility, and pressure redistribution. And all three things happen in concert in order for us to make effective interventions to prevent pressure ulcers. And clearly, the individual sits at the heart of that. So if someone has reduced mobility, so they're unable to reposition themselves, they're probably going to need a bit more immersion and pressure relief. But by contrast, if someone can move, they should be facilitated to move, and they should be on surfaces that enable them to reposition and to relieve themselves. So it's very much thinking about the three in concept, but putting the patient in the middle to say, well, what are their capabilities, what are their needs, and what are their preferences? And hopefully it's not a matter of blue trousers, green trousers, the nurse, all banging heads. It's about all coming together to make the right decision for the patient.
Okay, so again, we have another question here within the chat, and I'm going to open it up to the panel. How can we support our patients with maybe dementia or other cognitive impairment conditions in terms of, I assume this is maybe in relation to concordance or with maybe repositioning regimes. Anybody any experience of what works well? Eva, do you want to
Yes.
start
So
things?
again, I suppose we have had challenges with patients that have dementia. And I think again it goes back to trying to understand what the needs are of the patient, and that can be much harder with somebody with dementia. It might be harder for them to be able to communicate those needs. And I think that's when going wider is even more important, you know, talking to the carers, because most of the time they're visiting them several times a day, or maybe they're in a care home, so they know them best, them and family members. So I think it becomes much more bespoke. And again, I keep banging on about collaboration, but it's key. And I think if you as a team can try to identify what the problem is, or the barrier, or the challenge for the person with dementia, then you can sometimes go completely outside the box. And some of the things that we've had to do for patients with dementia are very outside the box. It might not be what's typical, but that is the point of holistic assessment, isn't it? And us all working together, I might not know what the physio or the OT knows, or somebody from wheelchair services, or you know, the people that know the patient the best. But actually, if we can identify why they're not following guidance, or, you know, what the problem is, if we can get to the root of it, sometimes we can try to optimize it in other ways. Yeah, and I think that's probably, you know, my best advice. It isn't one size fits all, and you know, there'll be some people that kind of standard things work for, and then that's great. And then there'll be another layer of people that actually are a little bit more complex for one reason or another. And their barriers might be more challenging. And so you've got to be a little bit more creative, and so on and so forth. And so I think it's just about being creative. How can you address those barriers so that you meet the needs of the patient at the end of it?
Okay, folks, I can't believe the time. I think we're 28 minutes past. I've more questions lined up for you, but I'm also conscious of the time, and really just want to say thank you before the webinar ends, again to all our panelists, but even more so to all our attendees here this evening. There's been some fantastic comments in the chat that I have been reviewing as we've been going along. Thank everybody for their participation in the Q&As as well. And we really, really hope that you find the most up-to-date version of the seating guidelines useful in your practice. And I know as a group of authors, we would love to hear some feedback from yourselves, you know, whenever you actually are out there putting these guidelines into practice. So I would just like to just to close and say thank you very much to everybody.